very good first day. I'm sure you did. I'm afraid I was listening to some of the first, and then because I'm 12 hours earlier than you, and I had an early clinic day today again. I couldn't hear all of it. I'm sorry I couldn't, but what I heard was really from excellent lectures. And I'm very honored to be a part and being asked to participate. Again, today I will talk about the core competencies, which were just published actually just a couple of weeks ago in the journal. And so the Journal of Occupational Environmental Medicine. So these slides were used with permission of the lead author of the current version of the core competencies, Dr. Natalie Hartenbaum, and I thank her for that. I added a few slides of my own just for context. So the work group on the occupational environmental medicine competencies were Natalie Hartenbaum, which I just mentioned, Beth Baker, both are former former presidents of the College of Occupational Medicine, as am I, Judith Green McKenzie, Jeffrey Levine, Kenji Sato, and Yusuf Syed. So the history was that the original set of competencies were actually published in 1998. Then there were updates in 2008 and 2014. And I was involved with the 2014 set. And in 2021, though, this year, the history is that the Practice Council for the Occupational Environmental Medicine proposed a review of all the competencies to determine if a major update was needed. And that was about a year and a half ago. So the president at the time, Dr. Bukta, confirmed the oversight and the practice review began. So in 2019, the preliminary review began. We asked residency directors of programs who are teaching new physicians in our field for input. And then we began in 2020 began the final update process. Fall 2020 was sent to the council for review. In late 2020, the documents finalized. And then we posted membership for comments. And then in early 2021, this year, a final version was presented to the board of directors and approved. In March, it was submitted to the Journal of Occupational Medicine, and a pre-publication copy was posted on the ACOEM website in March. And then in July, it was published online, and then later came on in print copy in the Journal of Occupational Medicine. So on the left upper side is the online version, and then on the right lower side is the actual one that's printed. It's actually a guidance statement, and you can actually obtain copies there. So there's quite a bit of diversity based on the data for our practice. Looked at what is the practice of occupational environmental medicine? What are different types of practices are there within the American College of Occupational Environmental Medicine? Well, 19% consider themselves in clinical practice only. 18% are in private or individual practice, 15% in corporations, 9% in hospitals, 7% each in universities, government, and other. 4% in the military, just a very few in utilization management, meaning you're looking at the type of care people are getting. And then there was 11% who just didn't answer the question. So you can see it's quite a diversity in the practice locations and styles of the membership. And in that same data set, we looked at all the different areas that encompass our very broad specialty of occupational environmental medicine. I think we have probably the widest, other than say internal medicine or the primary care, of the broad range of information, and it may be bigger than even that. It may be bigger than most other specialties at all. That if you look at all the things that we need to know something about and are important to us. But the main thing, if you look at this chart, which is a little bit busy, you can see that clinical occupational medicine is the most important aspect of the membership across the board. Second is disability management and work fitness, followed by patient care, practice-based learning, and workplace health and surveillance. And those four end up, if you look at that yellow line, it's about 80% of the respondents felt those were more important. Hazard recognition and evaluation and control, regulatory and governmental agencies, behavioral aspects of health, toxicology, preventive clinical medicine, clinical preventive medicine, health promotion and clinical prevention, and environmental health were the next rankings. Around 60% felt those as a group were more important. Then we have system-based practice, and that was about 55%. Business management, administration, public health and prevention, and epidemiology were lower. And then you can see that emergency management, terrorism countermeasures, health services administration, biostatistics, and aerospace medicine were the last of the and importance, but still quite important, around 35%. So we have to know a lot of various things. But it's important to realize and emphasize actually that the core competencies are just part, they're interrelated with other documents and papers that have been published from the college. And you see that at the top, the core competencies. On the left-hand lower side, you see the scope of practice, and this has been updated. I found the one from 1979, which I think was the first scope of practice report, and that's shown there. But there's been other, it's been updated many times since then. On the right-hand side, there are reports also that fit into the interrelatedness of these documents. On the right-hand side, I was the chair, I'm the vice chair now. I'm going to become the chair again next year of the Corporate Health Achievement Award, which is really an educational tool that shows the full range of quality improvement aspects of occupational environmental medicine. So I'd refer you to that the website is just, you can link to it, is www.chaa.org. And you'll see all the documents there, all the companies, international companies and national companies who have won that, and other types of organizations who have achieved high level of excellence. But these all interrelate. But I'm going to just talk about the core competencies tonight. So we've considered that the core competencies document itself are the skills that all providers who consider themselves able to provide services in occupational environmental medicine should be able to do. It could not be an all-inclusive document. Could not list, any and all tasks that might be done. So although this is again, it's a guidance document, it's not a complete document of everything that could possibly be done, but it tries to cover most everything of the important ones at least. So beyond each core competency itself, and you'll see this as it was written up as core knowledge and skills is one section, and then additional knowledge and skills, which are the that additional is with some occupational environmental physicians have additional knowledge and skills in some areas. But it's not considered core for all of us. And we did not think this would be a teaching document. It has not been over the years. Again, it's a reference document. So the guiding principles here for the core competencies, again, is a competency. What is a competency? Well, that's a possession of sufficient physical, intellectual, and behavioral qualifications, meaning knowledge, skills, abilities, and attitudes to perform a task or serve in a role while adequately accomplishes a desired outcome. That's considered a competency. Now, the purpose of the core competencies for our profession is that it provides employers, government agencies, healthcare organizations, and other healthcare practitioners a solid context of our role. So when someone says, what do? You can point to this document and show them. The term OEM physician is used here generically. It's without specification of board certification. So we're not saying this is a board certified doctor per se. So it's generic. And as in the past, it's essentially the same 10 core competency areas. The term health and productivity was updated to health and human performance. And the guiding principle here again is the document should be easily usable, easy to identify key points, additional information as desired. And this document is divided into 3 parts. And the first part, which I'll describe, could stand alone, or it could be with part 3. And I'll explain that in a few minutes. So part 1 is essentially an executive summary. It's the background on the document. It focuses on what is occupational and environmental medicine, the types of practice setting, the training pathways, and the 10 core competencies. Part 2 is the knowledge and skill sets for each core competency. So several sections under clinical, which I'll describe in a minute. The core knowledge and skills and additional knowledge and skills are on all the competencies. And there's some references and additional resources. So I think the team has done a great job in updating what was already a very useful and valuable document. In part 3 really are appendices. So the first 1A is which is the American College of Graduate Medical Education, which in the United States is what gives us our certification to be a teaching organization for medical students and residents. So it shows those. Part B is the Preventive Medicine Milestone Project for Occupational Medicine. And I'll just refer you, I won't go through that tonight. We don't have time. The content outline is part C for the American Board of Preventive Medicine for the examination. OEM research and education is next, and then competency and techniques and methodologies, research and education is last. So it's a lot in this guidance. So what changed? I mentioned earlier that they changed the term health and human performance. It was health and productivity, the last one was in 2014. They reevaluated all the content. We looked at our core competencies are now split with 2 parts: core knowledge and skills as one part, and additional knowledge and skills as the other part. And I'll give you a lot of examples. We may not be able to get through all these slides tonight. I hope we can. But again, I'll at least cover the clinical ones, the first one in some detail. And then the others, hopefully we'll get through, but it's a lot to cover. And I would again say it's at the Journal of Occupational Environmental Medicine in the July issue, and it's also online. So I definitely suggest you read this if you have an interest in knowing this document. In the past, some core competencies had just a clinical care focus and clinical specialist focus and population management. It's all been it's actually been cleaned up to make it easier to go through. So again, core knowledge and skills is one section of each core competency. Additional knowledge and skills is another part within each core competency. So it's two parts. And when we say core knowledge, it means that all OEM physicians should have the knowledge and skills to fill in the blank. And then for additional knowledge, some occupational physicians need to have this additional knowledge and skills, but it's not considered core. So I'll walk through some of these just to show you what they are. Again, this is at a high level, kind of a list. And the document has a lot more information, but I thought I would just share this with you as it is in the actual document itself. So first is clinical occupational environmental medicine, which is our core. So the physician should seek to maximize our patient's functional abilities, and we can all agree with that. There's a broad range of specialties in our field. I myself have internal medicine as well, and others are family practice, or they come from another specialty and have occupational medicine as their almost a subspecialty. Consider concerns of those individuals with underlying risk factors disease in certain positions. So we have to be able to consider those concerns. Utilize our knowledge and skill to identify those conditions which may present a safety concern or may be exacerbated by certain exposures. I think of Dr. King's a three-stage model, which I was very pleased to see that he discussed. That's what encompasses that idea. Then the clinical expertise may be applied to face-to-face care or for caring for populations. So the importance here is that not only are we taking care of individuals, but we're also caring for populations, which is unique. That's more of a public health approach. And I think that makes it stand apart from all other clinical type specialties. Here, this is kind of a generic look at it. For the clinical occupational environmental medicine, for many areas in this group, the idea is to recognize, evaluate, manage, and refer if appropriate. Then we evaluate a person's ability to perform strenuous or safety-sensitive work after some event, and the risk of sudden or gradual impairment or incapacitation to whatever that condition may be. We also think about applying our knowledge to the various risk factors, whatever they may be for that particular person or job, in their employee risk assessment and patient counseling. And then there in this document, it has examples, and we'll say such as, it's kind of the terminology for examples. So let's jump into it. The specifics. These are specifics now. So the first of the clinical occupational environmental medicine section is a general section. So the core knowledge and skills for this competency and subcompetency really is to obtain appropriately detailed histories with an emphasis on occupation or exposure. We should also be identifying potential relationships between medical complaints and the physical findings with the occupational and environmental exposures. So we find linkages and associations and make hypotheses about those. We interpret the applicable and relevant clinical laboratory tests and imaging studies in context of diagnosing, treating, mitigating, and preventing occupational environmental injury and illness and disease. That is our core knowledge and skills we must have in our profession. But additionally, some of us may need to perform utilization review and complex case management. I can think about COVID now as complex case management, particularly long COVID, for instance. We would perform what's called independent medical evaluations. I do 2 or 3 of those a week, which is provide an overview of a patient, examine the patient, and come up with an opinion. And we perform impairment rating examinations with specific sets of guidelines. For example, the AMA, the American Medical Association guidelines, there's about 6 editions of that. And I'm trained in, say, the 4th, 5th, and 6th edition, as each one of our states are different, and they use different ones. But those are additional skills and knowledge. So going into various subspecialties of medicine, here's cardiology as it relates to clinical, occupational, environmental medicine. So things we should know for cardiology that we must know is that we should be able to recognize, evaluate, manage, and refer if appropriate. For instance, the cardiac effects of chemical asphyxiants. Evaluate a person's ability to perform strenuous or safety-sensitive work after a cardiac event. We need to apply knowledge of cardiac risk factors and employee risk assessment and patient counseling. Additional knowledge can include performing cardiovascular evaluations such as stress testing, echocardiography, or diagnostic ultrasound to assess fitness for duty. Years ago, I used to do treadmill stress testing as part of evaluating for being able to wear a self-contained breathing apparatus, for instance. And some of us may be doing that. That's an additional thing. Dermatology. I see dermatology a lot. And I would say that we differentiate. Just a second. Okay. I see a hand up, but I'm not sure how to handle it. Know what to do with it. The core knowledge and skills, we should be able to differentiate occupational skin disorders. Well, things like burns, we can see first, second, or third degree burns, phenol, chemical dermatitis, contact dermatitis is very common, as you know. We should be able to be it to nickel. It comes up a lot. So we should be able to differentiate these occupational skin disorders. We should be able to identify and refer, if appropriate, any work-aggravated dermatoses, allergic contact dermatosis, allergic contact urticaria, or primary irritant-induced dermatoses. Additional knowledge might be to perform repair skin lacerations. For instance, I don't do a lot of suturing, but I do use glues for the minor lacerations. Where I work, they use scalpels and things like that, so it comes up. Perform testing of diagnosis of allergic contact dermatitis and atopic conditions. That's like skin testing with patches, which I don't do, but some can. And perform skin biopsies. I don't do it, but others may be able to have that additional knowledge and skill to do it. Sometimes it's useful and necessary. Emergency medicine. There's quite a few emergency medicine physicians who have come into our field of occupational environmental medicine, and certainly they have core knowledge and skills and probably additional knowledge. But I will say, for all of us, we need to be able to establish emergency procedures, protocols for the clinical management of individuals involved in hazardous materials incidents. So someone's exposed to, say, smoke, for instance, would be a good example. How do we handle smoke inhalation? Recognize and secure appropriate emergency care for life-threatening respiratory, central nervous system, renal, cardiac, or other target organ failures. We need to perform basic wound repair techniques, at least to temporize it till they can get appropriate care from a surgeon. And understand locally relevant emergency preparedness programs and triage concepts. And we have to understand how well our ambulance services are working and what the time is and so forth. I'm fortunate to have a very rapid response service, so I know them and we understand how they work together. Additional knowledge may be performing therapeutic and diagnostic injections, like injection in a joint or a tap for say a knee, swollen knee, or treat and manage simple fractures, including splinting and casting. A little beyond what I do, I would refer out to orthopedist, but Others may have that skill. Just checking the time here. So the clinical occupational environmental medicine endocrinology, core knowledge and skills. We need to select appropriate initial diagnostic tests to evaluate in the workplace related to common endocrine conditions. I don't know how many times I've seen people who have a very sluggish, a little tired, their voice has changed, their skin is dry, only to have hypothyroidism as their real problem, and not work related. Assess the impact of poorly controlled endocrine conditions on a worker's health and ability to work, health and ability to work. That obviously is typically diabetes, insulin-dependent diabetics, who, as you know, can have hypoglycemia or hyperglycemia, either way, and affect their work and become unsafe. To evaluate the role that endocrine conditions might cause or exacerbate work-related conditions. So if you have an endocrine problem, how can that be exacerbated by work-related conditions they have? For instance, those with hyperthyroidism or borderline hyperthyroidism, they get into a heat-induced situation very easily, and dangerously so. Treat and refer as appropriate endocrine emergencies in the workplace. The diabetic with, who's hypoglycemic, we treat kind of commonly, get them out of that, but they need to be, reestablish their glucose in a normal range as quickly as possible. Sometimes they suffer an injury because of that. I have seen that not infrequently. So we talk about gastroenterology within clinical occupational environmental medicine. And again, basically this section, this one core competency covers all the different subspecialties of medicine. Core knowledge here is that evaluate abnormal liver function enzymes in the context of evidence of exposure to workplace or environmental toxicants. That is not easy. So many people have fatty liver, but they're also working with liver toxicants in the workplace. What is due to what? Or they may have underlying hepatitis B, not uncommon. But how do we distinguish that from workplace? That's what we're good at doing. We need to evaluate personal risk of exposure to hepatotoxin agents. So, the person who does have, say, some liver damage to, say, hepatitis C or B, what is their risk working with certain, agents that could damage the liver? And evaluate gastroenterologic conditions and their impact on the worker's health and ability to work. A bleeding ulcer is a good example. Under hematology and oncology, we interpret hematology laboratory studies in the context of medical surveillance and post-exposure examinations. Those of us who do benzene surveillance, always looking for aplastic, lowering of the blood counts as a possible indication of excessive exposure. Perform clinical evaluations to detect health effects of exposure to hematologic toxicants, and to evaluate hematologic and oncology medical conditions or their treatment on the impact of workers' health and ability to work. As you know, there's so many people with chronic leukemias and other, or cancers, who are being treated with chemotherapy. How does that affect their ability to work? Very common, unfortunately. Additional knowledge may be to evaluate patients' clinical data and exposure data to render opinions regarding causation in suspected occupational environmental cancer. I know in my practice, I see sometimes firefighters who have, say, a leukemia, and was that related to, or myelofibrosis, was that related to their work for years in firefighting situations? Another would be mesothelioma and asbestosis. Not all asbestos, not all mesothelioma is due to asbestos. A lot is, but some of it isn't. So clinical occupational environmental medicine for infectious disease. Now, how could be what's more appropriate right now in this pandemic than infectious disease as being a core knowledge and skills that we need to know. So we need to identify, manage, treat, and refer for treatment and implement steps to prevent or mitigate bloodborne, airborne, like COVID, waterborne, and foodborne pathogen exposures and associated illnesses. And frankly, this is what is really exciting to me about occupational environmental medicine. If you look at all these core competencies and all the things we need to know and understand is very, very fascinating. You could never, ever learn it all. If you're a learner, a lifelong learner, this is the field for you because there's so much to learn. And it doesn't stop. Again, COVID is a good example. We're learning, seems like every week, something new. But we apply that to our work and what we do. So we need to apply CDC, Centers for Disease Control, OSHA, other requirements and recommendations for infectious disease prevention, surveillance, exposure, evaluation, and treatment. COVID is an obvious example. Understand the role of occupational environmental medicine physician as it relates to endemics, epidemics, and pandemics. And this was written, it really started in 2019, so really before this pandemic. As you recall, we had avian flu and MERS and others, SARS. So we've had know this, and now we have to know it even more. So additional knowledge and skills within this area or sub-area, infectious disease, is to evaluate travel medicine issues and provide appropriate advice and treatment. I don't know about you, but I've been involved with travel medicine issues for years as a corporation that sends people around the world. Everybody's traveling, or even for personal travel. What are the issues? How do you have to know travel medicine and all the aspects of that? We have a plant in India, Chennai, India, for instance, and that and other places around the world that have to know a lot about travel medicine. Malaria, vaccines that should have polio vaccinations, typhoid, so on. We need to be able to participate in research and education on infectious disease and unusual zoonoses. And also manage specific occupational infectious diseases. Obviously COVID could be is an occupational infectious disease in many cases. Most cases it isn't, but it is in some. Where I work, we actually have COVID, the virus, working on it. So it is can be an occupational infectious disease. That's just one of many. And here we are at the musculoskeletal, which actually occupies a big part, I think, of occupational environmental medicine physicians' practices. Because here we're talking about, ergonomics, and now with people working at home, it's even more of an issue because they have a laptop on top of their, kitchen table, whatever. So this is one example, but but actually ankle sprains and knee injuries and shoulders. There's a lot that happens. A woman I saw earlier this week was lifting, 25-pound tank of solution, and now has tendonitis and left elbow is restricted. That's an example. So we need to perform focused and comprehensive musculoskeletal evaluation. So we really need to know how to do that. We need to know how to examine a knee, how to examine a shoulder, elbow, all the joints. We need to utilize our knowledge of the pathophysiology, evaluation, and management of work-related musculoskeletal injuries. We need to interpret common diagnostic studies used for, basically X-rays. I'm not good at reading MRI scans, so I leave that for the radiologist. But I can read an X-ray. Again, with a radiologist overread, but we need to understand how that looks. So what does that mean? What does calcific tendonitis in the shoulder mean? That kind of thing. So understand the options and controversies in the treatment of musculoskeletal conditions. Low back pain, for instance. We have a whole set of practice guidances, where there's evidence-based, looking at those conditions and what the science is saying about best way to treat and to diagnose. So additional knowledge and skills might include utilizing diagnostic tools. I mean, some people I know you can use ultrasound themselves, looking at, say, the knee joint, to perform diagnostic and therapeutic injections, like I mentioned before, injecting in the knee, or performing casting and splinting. Again, beyond what I do, but that's what I do splinting, but not casting. But some can do that. And then neurology. Look at the time, 9:36. Okay, we'll probably just get through the clinical medicine ones, which is fine, because this is probably the major focus for a lot of people. But I will say there's 9 other competencies that you may want to look at. I would definitely say you would want to look at. But this one is neurology, and how much we've seen this a lot. I mean, so the core knowledge here is perform focused neurological and mental status examinations in the evaluation of occupational injuries or illnesses. I have monofilaments that I touch, the fingers of the toes to see what they have sensation. I have, tuning forks to check for vibratory sense, and that test the dorsal column. And I have seen those turn out positive. Also, we look at, looking for radiculopathy, of course. So we need to recognize the neurological emergencies and treat or refer as appropriate, be it a stroke, say someone is post-ictal, had just had a seizure, but somebody may not have seen it, or did see it. All these things, neurological emergencies. Of course, again, the back pain has red flags, loss of bowel or bladder control, for instance. Can't lift their leg all of a sudden, or lift their toes. You need to collaborate with the specialists or primary care providers to appropriately treat and determine if it's safe to come back to work or to continue work. To understand and interpret diagnostic testing, nerve conduction, ENGs and EMGs are classic. So we can find out whether or not this is a neuropathy due to a polyneuropathy, say due to lead, now versus diabetes is a different pattern. So additional knowledge may include diagnostic testing or treatment utilizing ultrasound, nerve conduction tests. Some people know you do that. So I think those are nerve blocks, things like that, which is additional. I don't personally do these. I refer those out. Ophthalmology. Well, I think we're all involved with some sort of eye exams to be able to see if people can do the work, in which we have to be able to do this, including visual acuity, color depth test, and assessment for foreign bodies in the eyes, which is very common. This is a very common thing for us. We need to recognize or treat or refer to a specialist as appropriate. Is it a simple conjunctivitis, or do they have a viral pink eye type conjunctivitis, or is it a serious inclusion type of eye problem? Identify the need for specialized ophthalmologic evaluation. That's for me a very common thing when I see eye problems. Additional knowledge, maybe a slit lamp examination. I don't do those anymore because I don't have the equipment. And if you don't do it often enough, don't become that good. But that's something a lot of people do. You can measure the intraocular pressure. I used to do that more. I picked up a lot of, early glaucoma. Utilize diagnostic tools such as ultrasound to look for ophthalmic injuries, and remove, superficial foreign bodies. Some people do that. ENT, very common. Again, as you know, We see a lot of this in the clinic. I do practically every day. See less of it now, actually, because of COVID, we're not having people come to the office. If they have, you know, screening symptoms of COVID, we can't have them come. So we do this by telemedicine. So we need to diagnose and manage ENT conditions, identify a noise-induced hearing loss, and how to prevent further damage. That many of us have hearing conservation programs under OSHA, so that we do in audiograms. So we put on the headphones. How do you interpret an audiogram? Identify a standard threshold shift and implement appropriate treatment. How do you develop and implement and manage an occupational hearing conservation program? These are things that only we do. Even the otolaryngologists don't do this. We do it. And how do we evaluate the impact of hearing abnormalities for fitness for duty? The person who can't really hear well, who's in a say driving a fork truck around a warehouse, but really can't hear out of one ear, for instance. How is that going to impact if somebody says, "Hey, stop that truck," and you know, it could be a dangerous situation. So additional things, we need to perform audiometric testing, how to do a hearing loss causation analysis upon looking at all the audiometric measurements. Those things I do, and evaluate and manage patients with complicated nasopharyngeal conditions or aggravated by occupational exposures and so on. That's additional. Pain management, and then I think I'll probably wrap up at that point, because I didn't think we'd be able to get through all the rest. But these slides are available. I had provided this. And again, I would encourage you to go and get a copy of this from the either the website or through the journal. So the pain management. How do we understand the difference between acute and chronic pain? And they're obviously, as you know, they're different types of pains. Yeah. Central pain versus peripheral, so on. It's treated differently. Utilize the pre-treatment approaches that will help patients with pain to maintain optimal performance. And refer to a pain management specialist as appropriate. And that comes up kind of often. So additional skills may manage long-term opioid therapy. This is area, or how to manage outpatient opioid detoxifications. I don't use opioids at all, so I don't have this additional scholarly knowledge. I'm aware of it. Or perform diagnostic testing or treatment using ultrasound and these other techniques. I think I'd add to that acupuncture. Psychiatry. Right now, I had a young man in the office last week, just really so upset with just how life is going right now and work under extreme stress for a number of reasons. But this is becoming more and more of an issue, and it always has been. Occupational stress is something that's probably, at least in the United States, is not recognized and treated well, in my opinion. So we should be able to identify and refer as appropriate, which I did with this young man, impaired employees with mental health in this situation, or drug abuse issues. Drug abuse with COVID is going up. Suicides are going up with COVID, as a matter of fact. So we need to be able to look for those warning signs. So workers who may be under the influence of psychoactive drugs at work, we have to be able to identify that. That's a core knowledge. And support access to psychological care. Others may be able to identify and assist in management of psychological stressors in the workplace. They may participate in implementation of workplace mental health programs and participate in design of violence prevention and response programs. Those are things some of us do, and some of us would have others do. Pulmonology, I mean, this is a classic, obviously. We look at either asbestosis, cirrhosis, you know, all the, or the various, you know, in a book that was coming out on called Research and Educational Institution, Occupational Environmental Medicine, I contribute a case of this pulmonary case to that book, which should be published. Phil Harbour, by the way, is the editor-in-chief. It's a new book. It has not been published before, but it has a lot of pulmonary in it. And so if you're in those fields, I would just, you might want to look at that book when it's published. I contributed to it. I have no interest in financially in it, but that's just simply a, because I see this kind of thing. So as we all do. So how do you identify and diagnose and treat it? Because if you never identify it, you don't know that it's there. So we need to understand how to do that. How do we identify and recommend appropriate work restrictions, accommodations? Can they wear a negative pressure respirator? Perform respiratory certification exams, which I do almost every day to see if people can wear negative pressure or SCBA. Additional knowledge may be perform and interpret or refer as appropriate diagnostic testing for pulmonary disease. Beyond, we do simple spirometry, but this is more real pulmonary testing. Or become a B reader. Or you be an A reader. There is such a thing as an A reader, by the way, but a B reading is the one that's ILO uses. Reproductive medicine, and I'll be wrapping up here in a minute. Identified perverse, all the reproductive outcomes. This comes up a lot. Identify up-to-date resources of reproductive toxicology. Recommend appropriate restrictions, that kind of thing. And other additional skills is advise on policies and procedures to protect fertility and so on. Sleep medicine, this is a big area for truck drivers, those of us who, as I am, a DOT, a Department of Transportation examiner. Sleep apnea, obstructive sleep apnea is a key thing we need to recognize, as well as circadian rhythm disorders or fatigue. Refer for evaluation for diagnostic testing and evaluate the impact of sleep disorders on fitness for duty. Comes up all the time for, say, commercial drivers, but also for others working, say at even control panels in a chemical plant. You have to watch out for that. So I don't have time to go beyond this. I didn't think I would. I think I've used all my time. Other than to say there's the next sections, or for instance, this one is I'll run through these very quickly. I won't go through all the detail, but I'll just show you the rest of the core competencies. Here we have OEM related law and regulation. When you're an international physician, there's so many different laws and regulations, it's hard to keep up. And I've been in a situation like that when I was a corporate medical director at Lockheed Martin or at Exxon. You just got to know these. And it's hard to keep up, but you have to know them. I'll skip through that. There's a number of things that we need to, that just explains what those cores and additional are. Environmental health is the third one. Again, I'm going to just skip through this. I'm not going to read them. You'll be able to do that. So there's the additional knowledge again. Number 4 is work fitness and disability management. Again, the whole set of core knowledge and skills, followed by additional knowledge and skills. Toxicology, the Ramazzini things we need to know from years ago, and it continues. For our knowledge, we have to continue knowing about all the different health effects. And it seems like from time to time, some new ones come up. Popcorn workers, inhalation, pulmonology, for instance. Hazard recognition, evaluation, and control. Obviously, we have an industrial hygienist in many countries who help. You're very familiar with the hierarchy of controls. We know this. I can't think of another physician specialty that knows this, except perhaps in the medical centers now with COVID. Disaster preparedness and emergency management. We certainly Have to know this. And this, again, an area that's a specialty for us. Health, this is a new one. It's been renamed. This is the health and human performance. For instance, what is that? It's like recognizing burnout in employees, for instance. Burnout, as you know, particularly in healthcare staff, is tremendous here, at least here in the States. And probably I know when I was in the UK talking at the Society of Occupational Medicine there a couple of years ago, for a speech, they were telling me about the burnout because they had such a reduction in staff. There again, there's all these this is kind of worksite wellness programs and so on, well-being. You see all those examples. Number 9 here is public health surveillance and disease prevention. A lot of us, obviously, in public health are involved with this. And how do you do medical surveillance programs, so on. Core knowledge and skills. And then lastly, occupational-related management administration. If you're in any sort of managerial role, or even just trying to manage your own practice, these are important things to know about. Particularly this because this incorporates IT, and we're all using IT now. So what are potential uses for these competencies? I think ACOEM may develop broader educational offerings with this breadth of practice to show employers and organizations what OEM physicians actually bring to the table. Describe the breadth of OEM expertise and practice diversity. And American Board of Preventive Medicine may update their own core content for their occupational exam in the future. So I think there's time maybe for a question or two, but I know that we're right at, I think, on the hour, so close to it. So at this point, I will stop, and I appreciate being able to share this with you. I'm very excited about it. From my previous experience helping to write and prepare all these and publish them. Also, I'm working on the scope document, as I mentioned, and also on the Corporate Health Achievement Award. Again, all these things fit together, but I think we're in an exciting field, and it doesn't reduce. In my years, over 30 years, it's gotten more and more complex, at the same time more interesting and fulfilling. So thank you very much for your attention, and I hope you have an excellent rest of the day on your meetings. I think this is wonderful that you're having your conference, and I thank the organizers for inviting me.
He asked that what kind of individual practice of occupational physician in United States?
What kind of individual? Curious. Curious. I think the key is intellectual curiosity is the main thing I've seen over the years. I've had residents with me, working with me, and students. I'm on staff at associate staff with Johns Hopkins University. So I think I'm always amazed that intelligence and curiosity seem to go together. And I think, but it's also not just that, it's also the interest of helping other people. I think this is a field, I think it's underrated. We're a thinking specialty, not a doing specialty. We don't, we're not doing fancy surgeries, getting all kinds of, attention for that kind of thing, saving somebody's life by doing a surgery or whatever. But we have an opportunity to not only affect individuals, but also groups of people. So I think for me, that's very important is the idea we're taking care. To me, the workforce is like that I take care of is like a family. And you're taking care of a broad group. And you can impact all of them by just making a little change in things across a lot of people makes a big difference. So I think that's the idea of population thinking and not just individual thinking is extremely important.
Thank you, Dr. Chow, for explain the character of occupational physician. Excuse me, Dr. Kshatriya has raised her hand. She may have
Thank you. Thank you. Good evening, Dr.
Good
Yarborough,
evening.
for your
Yes.
thank you for your lecture. I'm Kshatriya from the Faculty of Medicine, Ramayatipudi Hospital. Your insights are very beneficial to us because we are going to launch the residency training program next year. So
Wonderful.
It's very beneficial for designing the learning experience. Yeah.
Yes, absolutely.
Yeah, and I have a question for you. Should OEM physicians act as a primary care provider of the workplace? Because in some restricted resources setting, like Thailand, some working populations, they have very limited access to primary care. So what is your opinion on this? Thank you.
I think yes. I think they can. If again, being a primary care physician is what I am also as an internal medicine specialist can do primary care. Do some and have. So I think it's important. Depending on your resources, it certainly can do that, and I agree with it. Because I know in a lot of countries it's necessary because of limited, physicians. Anyway, it's something that would be useful. For instance, in Mexico, when I had plants down there, that's exactly what the physician was also an occupational medicine physician and a primary care physician. I will say it is somewhat difficult. It gives challenges because when you're an occupational physician, you have to make sure you tell them, okay, I'm acting as a primary care physician here, or I'm acting as an occupational medicine doctor here, and for this situation, because I think it can get confusing. Because when you're a primary care physician, you're an advocate. You're working for that patient. When you're an occupational medicine physician, it's a more objective. You're not really working for the patient. You are, but you're also thinking broader in terms of the relationship between their work, and you're offering more of an opinion. So you're trying to take an objective, step back approach. So when you give a work restriction, it's appropriate for occupational medicine. As a primary care physician, they may be saying, well, why aren't you letting me go back to work? You're my doctor. Why don't you tell me so you get caught. You can get caught. I think it's not easy sometimes to make sure that sometimes the doctor can get kind of confused which what they're doing. Are they doing primary care or they're doing the occupational medicine part of the interaction. So usually it's not too much of a problem if it's hypertension, but what happens if the person comes in with very high hypertension? They come in and see you as a primary care physician. They have really high blood pressure, 190 over 120. Now, as a physician, you'll take care of the high blood pressure, but you're thinking of occupational medicine. Are they safe really to go out and work? And the person will say, hey, wait a minute. I came to you to take care of my blood pressure, not to let me, to keep me out of work. So that's an example I've seen. So I think it is an extra attitude and skill that one has to develop. And that's kind of the art of medicine, right? There's all these things, core competencies, things we need to know, skills we need to have. That's sort of the science, is the art. And so, which I think is just as important. And that's part of the harder part. And some people, develop that faster than others, and they can be mentored along on how to do that. I think mentoring is very important if you have that dual role, to have somebody to go to and talk about. This is my situation. What do you advise? I think it can be done, but I think it's having someone to talk to, an experienced, primary care, occupational physician type person who's been through a lot, seen a lot, has experiences they can share. I think it's very important to have that as a way to get through those issues. But congratulations on having your residency program come up. That's fantastic. Yes.
Can you hear me, Dr. Yarborough?
Now I can, yes.
Okay. I have something to share with you. First, I want to ask how many types of doctors that practice occupational medicine in the United States? Not only about 35, you say that, but there is other doctors who practice occupational medicine.
Yeah, we did a survey of that when I was vice president, and that's a very good question. Actually, most occupational medicine, occupational environmental medicine is not performed by people who are board certified or have, that is their primary specialty. Many are doing it now as a second thing. So if you look how many, we're not really sure. We think maybe, and that with board certified is, I have to look at the numbers again, maybe 3,000, something like this. I think the number, we think the treating, doing that kind of work, this kind of work, some part of it, usually not everything, but some part of it, maybe 10 times that many, maybe more. We're not really sure. So that's why we're trying to get this kind of information out, not just the ones like us who are involved and dedicated to occupational environmental medicine, but to all the others who are kind of doing it, maybe on the side from emergency rooms, the urgent care centers, from primary care centers. I know sometimes I work in a volunteer clinic for people from who don't really have any insurance. It's very poor people, and I'm identifying occupational medicine issues a lot. For agriculture, service industries, that kind of thing. That that in that kind of group. But if I was just a primary care physician there, I wouldn't know all this kind of thing and be able to help them out from the occupational medicine side as well. So it'd be good that we need to teach people who are doing these kind of other jobs at least an idea what to look out for when they should be consulting with with expertise like us in the area of occupational environmental medicine. I think that's extremely important, and that's part of the reason for these for this document.
So, from you, I think, thank you for your lecture about this.
Well,
when
thank you
walk through that PowerPoint, I think that it's a really hard work to walk through that. I read the paper, the competency, the new competency. I already read it, and it, I think it is a sell point for occupational medicine physician. We can show that to our customer, to the worker, that is me, the occupational medicine physician. I think our role is different from the occupational health nurse or industrial hygienist. I think it's very clear. In Thailand, we just changed our residency training program to suit the World Federation Medical Education, or WFME. So now the resident has the EPA, we call enforceable professional activity for 5. Number 1 is evaluating health status by using occupational medicine principle. EPA 2 is doing health promotion. EPA 3 is a medical surveillance. EPA 4 is a diagnosis and disease injury management. We use the word management, not treatment, because we have to manage those sick, return to work, fit for work, or something. Yeah. And number 5 is disease injury and infectious disease investigation in the workplace.
Yeah.
I think in this we can separate to the core competency of that present by you. I think it will cover all, but it may be written to be clearly than use a big word like this.
Yes.
Okay, so
yeah,
so we,
absolutely.
And in Thailand, doctor cannot, most doctor, 99%, 98%, I think, cannot work in the factory because there is no law that the factory must have the doctor for consultant or must have a doctor to work with the occupational health team in the factory. So most doctors are in the hospital. I think in Thailand, the curriculum for residency training is purely preventive. Yeah, not like in the United States. Just like you finish internal medicine or finish emergency medicine and took occupational medicine training or occupational medicine. So we are purely preventive. So when we are in the hospital, it's easily to refer the patient to other specialists. So I think our curriculum is not complete. It lost some core competency that you present. So your presentation is very useful to us.
Yeah.
Maybe we consult you.
Well, sure. We're glad to. But I will say this. I think we looked at the document. It's a lot. I mean, it's a huge amount. I think it's an ideal. One way to think about it is a goal, an aim, as opposed to maybe it's not necessarily achievable everywhere for everything. Just from a practical perspective, given that regulations are different. I know I've been in Europe a lot of times, and it's they have different regulations where things get done because as a regulation, the occupational physician has to do it. In other countries, it's not that way. So it's just more of a sell and what's good practice versus what's regulated, necessary, just under law. So every place is different. That's why I think it's I think it's something to look at and see what might work. But we try to be very complete with it, just to cover everything, and then have those additional things that are just added on if as need, as skills allow. So again, I think we have one of the more complicated specialties that there is.
Professor Vilawan, do you have some questions? One more question. Okay. The last question of Professor Vilawan.
Maybe we can discuss more next time, because this time I think we already get a very full information and learn a lot. Thank you so much.
Well, thank you. It's a pleasure. It's just my pleasure, really. I love talking about this kind of thing. So thank you for asking me.